Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 184. It's a beautiful October morning in New York City, a lovely autumn day, and we are delighted to have you join us. There are two things I want to mention before we start this extremely useful and exceptionally challenging teaching case. It's a CTO where you will come to learn our approach to it, how we decide the approach, antegrade versus retrograde, and all the technical tips and challenges. So with this introduction, let me take you to the Cardiac Cath lab where Dr. Sharma and Dr. Kinney are there. Samin, good morning.
Beautiful, and welcome and greetings from Cath Lab to our lively and ever-growing CCC live webcast audience. And today's case is especially complex because there is a lot of demand for the CTO cases. Because we are, I think, to globally we have taught everybody the rotablation, the left main, calcific bifurcations, what they need a little more on the CTO. And this is what we are today to show. Okay, this is a 55-year-old male. I would say that probably one of the healthy patients we are presenting in over 184 cases who does not have any much risk factor, little high lipid, very well controlled, as you can see, on only taking aspirin, torvastatin, SAQ score 75, good BMI. All the risk factors are very good with LDL of 58, probably should be 55. Had a little bit of elevated A1C, but not on any medication. So he presented about a few months ago with class 2 angina and has a known intermediate 2-vessel CAD about 6 years ago. So Cardiac Cath now revealed 2-vessel RCA and LAD diagonal bifurcation, and LAD was completely occluded with a JCTO score, very adverse morphology. All JCTO 4 points are there, and I'm going with a syntax score 26 and normal EF. So Anu will show now. We did the RCA PCI. So show the results now. This is okay. LV, show this.
LV was normal.
Yeah.
Yes, normal EF,
Yeah.
and this is the right coronary artery. Previous PCI there. Yeah.
No RCA injection.
Oh, we didn't do.
Okay. All right. So RCA looks good. The injection is there, but look at the LAD complexity. Calcium, long segment, and bifurcation. And you tell us what your strategy will be, where you think the stump.
I don't see the calcium.
Yeah.
Non-calcified, but let us tell what are the JCTO score here. One, if you see that length, definitely just maybe 20, right? About
more than 20, yeah.
So that one fits there. And other one is, one thing is we can say it's tapered rather than blunt.
Yep.
Yeah.
Blunt.
And no 45-degree angle there. That's one. No calcium, I would say. So we probably will get JCTO score of now the side brand. There is only one challenging issue there is that the septal, though it's small, there is a septal which can interfere into getting in just into the CTO proximal cap, just at that level. That's a large septal. That's the only challenging part for us.
Anu, my observation is this may turn out to be extremely challenging, or it may be straightforward. So let's say if it is straightforward, could one make an argument that, look, let's just give it a quick shot first with the wire before getting a contralateral, or it absolutely is mandatory and makes complete sense first to have a contralateral?
Yeah, because if you just do a single picture of the LAD, which we don't have here, but we had in diagnostic, you could not see the distal LAD. Right. Distal LAD was only seen when we did the RCA picture, especially with this, we cannot call it as a circle of Xience, but since it's not from the conus, but you see it, it's almost, yeah, okay, it is. Yeah, it is from the conus.
Yeah, circle of Xience.
It is a circle of Xience.
Which also gives you some suggestion as to the chronicity, no?
Yes. So only from the RCA injection, we could see the LAD collaterals, even in our diagnostic. That is why, very important for the success rate of CTO, you need to have dual injections. So you see the distal vessel. So you can, pierce a proximal cap. Depending on how chronic it is, you will be able to traverse the CTO. But how do you know you're in the true lumen or no? You need to have the contralateral injection. And sometimes you could be subintimal as you're entering the distal cap. You can pull back the wire and navigate into the true lumen. For that, you definitely need the contralateral injection.
7 French.
That's what right now we were just discussing, me and Pratish, that we likely may need a 7 French because diagonal is significant and almost like a dual LAD, larger than the size of the LAD.
And you have the access in both femorals?
Both femorals, yeah.
Okay.
I mean, that's another thing. You want to do both femoral, both radial, whatever people's choice. For me, both femorals are very easy because very, easier for us. If you cannot do the right radial, because then you have a little gap for the operator. You're standing way away. So you also see the ergonomics of the interventional cardiologist. I think I want to give one day a lecture of ergonomics for the interventional cardiologist, because the musculoskeletal issues are becoming very high among interventional cardiologists. So it's better you stay closer, comfortable, and stand straight, and you are able to do your procedure, rather than you are you have your radial board and you're staying a little bit further away and all that. If it takes a longer time, you will start having your upper back and lower back issues.
L5S1.
Yeah.
Or then do a left radial. If you really want to do a radial and femoral, it should be left radial and right femoral.
Yeah, but even then you will need a massage person to stretch your back.
The strain with the...
It's a lot.
So, I mean, just going with, 35 years of PCI, never seen a harsher guidelines downgrade of any entity than CTO. Looks like they are truly discouraging us, and you think it's all on the basis of clinical trials or even the length of the procedure, radiation exposure, chronic kidney, all sorts of aspects?
Yeah, I think that all of those factors and that basically that every trial, that 4 of them, the decision, Euro CTO, and you name it. So all of them have shown no benefit. Even you say quality of life, maybe we are talking about only quality of life measures. Even quality of life measures were not different. So they've taken all together, they came up with this guidelines that you have to have showing ischemia, refractory case. So in this particular case, what we did is to become class 1. Why? Because we did a FFR of the LAD diagonal, which is positive. That's how we did FFR of the RCA, did the PCI. So clearly in the CTO segment, we did not have a stress test in this patient particular. He is a young person. And then 6 years ago, we have the angiogram. LAD was fine, 30-40%, 30% disease. Diagonal, actually LAD was about 50%, diagonal was 30%. So these are all progression of the lesions in both the RCA and LAD, which was 6 years ago. This is despite his LDL around 60. Actually, LDL today is even good range. LDL is 55 now. Of course, HDL is 39, which is very tough. There is no treatment for it unless you do a lot of exercise and so. But so this case with almost no CAD risk, or minimal, I should say, CAD risk factor, has a progression of disease and silent progression of this LAD. And good LV function. So clearly, there are studies also have shown that does revascularization of the CTO improve the LV function or the perfusion abnormalities, and answer those have been negative. So all those have put together into this 2B category of the CTO. So both of them, one, the LV assist devices, because there is no clear-cut data yet, and secondly for the CTO. That's the one in 2021, our revascularization guidelines were very clear that, unless it is necessary by clinical indication, then only you go for intervention.
No, we have to decide now, do we go to 7 French?
6
then
is
have
okay.
to change
No,
it
6.
right now.
No, 6. 6 is good. So diagonal is there, but I think if need to be, we can always do a mini crush or a reverse crush or so. But 6 French will be good.
Step crush, not reverse crush.
Or a step crush. Yep.
Too many steps.
Okay, so let's go to presentation while we are getting your first wire. You're doing a fine cross and fielder wire, and you go to there, and what wire will be using after that? First wire.
Yeah, now the first wire, that's it. What would people use? So you could go with Fielder. People may want to start with, a lot of people who like Fielder XT, right?
Or
That's
Gaia?
one. No, the first wire you can still try. Pilot 50 people like. So Fielder XT, Pilot 50. And after that, if you need your next wire, yeah, people may want, Gaia could be okay, but I would go with Miracle.
Yeah. No, clearly that here does not look like calcium. The earlier angiogram appeared, but there's no calcium here. Okay. We go to click present. So what is your choice? As soon as you bring your catheter there with a Fielder, what is your next wire you're going to ask for it?
I will go with Miracle. But if somebody will say they want Gaia 2 or 3, that's okay too.
That's okay. Go with Miracle 6. Okay.
Yeah.
Let me just complete my presentation. Go back there, please. Yeah. So basically, this is where patient has isosorbide we added on this patient. So plan for a stage PCI of LED diagonal bifurcation and long mid LED CTO lesion using Antegrade Approach with contralateral injection. So clearly, this case, because of the positive FFR and anti-ischemic therapy is appropriate. So that's where we are now. Let's go to our presentation. Let's go on fluoro again. Okay, so we are coming with a Fielder and fine cross.
So Samin, with the modification
No, it's fine.
in the calcification, the JCTO score, of course, changes.
Yeah, so JCTO become 3.
3.
So, yeah. Because that angle is there because it's a very small stump, whether it's a blunt cap, ambiguous cap. So if it is a clear cut taper, then it become 2. But here I think with the guide little better. Okay, tell us what you are doing now.
No, I'm there. I'm just trying to tell Samir, how do you decrease the radiation? See, I've got the collimators inside now.
Look, this is the single easiest and the most effective way to reduce radiation, which people don't use. And I'm so glad you're doing it.
Yeah.
I know most of your cases you do in how many frames?
Mine, if I do from skin to skin.
No, frames. No,
frames.
15?
Frames we are,
it's still 15, yeah.
15, no? Yeah,
Yeah,
excellent.
yeah. No, I know there are suggestions to go to 7.5.
Yeah, the many
so we are doing
going.
diagnostic in 7.5 now. Like, like a pre-op tower, just cath only patients are coming. We are doing it to 7.5.
Look, when you mentioned that, I think I'll just briefly talk about it, and at some stage we should devote more time on it. Particularly with you, I have noticed there is a optimal balance in just about every case between radiation protection and protection to your own spine. And I think those are such important matters. If this is a profession where you're going to be spending 20, 30 years, you cannot be having early development of cataracts and neck and spine issues. Exactly what we thought going into the diagnosis. So, suggestion of an ambiguous cap.
Yeah, definitely.
Now here you see that many times the Fielder or any kind of a polymer jacketed wire will not help you navigate into the smaller branches. So if you want to change right now why other one is good, because it has a hydrophobic tip, which the Miracle has a hydrophobic tip. Now let me see, I'm going there slowly.
Yeah.
Now, but remember, this is where our challenge was. Now I'm getting into the septal. Yeah, some dye, little dye. Yeah, that's the septal.
Actually, today we have the CTO seminar in Mount Sinai. We have 7 CTOs. Usually we are very careful about 3 or 4 maximum, but today they happen to be by chance 7 CTOs on the schedule. This is the first one to start.
Both of you will glow in the dark tonight.
I already told that I'll be here past midnight.
I was just watching your board. There is a pretty extensive structural cases too.
Yeah, and 5 structural cases also.
And tri-clip.
Right.
And,
so those actually on Monday, Monday and Tuesday we have the OR. So that doesn't affect the cath lab schedule directly. But still the staff is involved and fellows are involved and so. But the rest of them, the key is that the referral cases. So I actually have the designated like 10 interventions. 7 are referred by outside, and two of them have been
miracle.
failed outside. So you know that those cases are very challenging and they will take a lot of time. And so,
I
but
mean,
that's
they
okay.
are a failure of a case is included in the complexity and the classification.
Yeah, that's right.
Absolutely.
Exactly. JCTO score that you have failed
Right.
attempt is
Right.
one of the important factor.
So I'm changing. So now I am able to get it halfway through. You see that?
So
Almost navigated halfway through. Want to change it to a stiffer wire. You see the...
So where you have the wire at the moment, do you think it would help to image that?
No.
No,
Or
no,
it's
no,
too
no.
premature there?
Too
Way
premature.
Too
way
premature. No, no, no.
Okay.
Then you need a 7 or 8 French there.
Yeah,
No,
yeah, yeah.
we don't have
Okay.
that. Yes, yes. That is to tell us whether you're in the true lumen or no. Right now, it looks okay. So we'll change. Now, at this time, if somebody wants to change, we already gave you the first wire of choice, Fielder XT, Pilot 50.
So
Okay,
we are
whatever people like.
going down the pathway of antegrade
Wire escalation.
wire escalation.
So now I'm going to this one is Miracle. So you have Miracle 3, 6. I took the 6, or you want to go to Gaia 2, 3. Any one of them is okay. So Gaia has come with a pre-shaped curve. So
Anu,
good thing
and
about Gaia is that it is a hydrophilic tip also. You know,
all these
hydrophilic
steps,
coating, hydrophilic tip. Yes.
the wire escalations you're doing are all illustrated in the app.
Yes.
So that would be another useful adjunct if people want to do it. Get hold of the CTO app and
Give me
follow
the
the
retro.
case along.
Guide wire.
Guide wire app. Yeah. So right now you have Miracle 6, right?
Yes, yes.
Okay. So some people, I would say if you want to take the vote, many people will go with the Gaia 3 now. I mean, I would have gone with the Gaia 3. AK wants, she likes the Miracle with the being a hydrophobic tip. So Gaia versus Miracle, I think it's
Retrograde.
yeah.
So it's been a while since we did a CTO.
Yeah.
Is your belief still that you stay away from the antegrade dissection approach?
Both antegrade dissection as well as the retrograde only if you're to fail antegrade. So a lot of people start with a retrograde, and so I can tell you retrograde still require a lot of area. Yeah, looks good, very good. No, it looks good. Yeah. Good. And remember any of this, yeah.
Your own individual class 3 would be epicardials.
Yeah, that's right. Okay, now you can take the injection and you'll be good.
You know, it's strange that with the wire making such good progress, the guiding catheter is still backing out, suggesting as if you are still...
Yeah, no, good. Yeah. So they always will do because it's a long segment. Yeah. Good.
Right. No, that was not the long segment. It was the, the other collateral, which was circle of Xience, which this catheter is blocking now.
Yeah.
So you see how you'll advance.
Exchange length.
Are you showing my finger movements? Yes.
Yeah. They're showing the hand movement, rotate and advance. And no PVC. That is a good sign that you are in to the true lumen. And not going epicardial.
Okay, 300, run through.
And get a 2020 compliant. 2020 compliant balloon.
2025 SS.
No, 20 first, and then we can get 2.530. 2020 and 2.530, yeah.
Anu, in your own mind, what criteria have you established to call off a long, difficult CTO? Is it radiation level? Is it amount of dye? All of the above?
All of the above. More important is, you see that, the time taken from proximal to distal cap.
Right.
I take it out.
In some ways it is disappointing that, almost a decade ago, the separation between men and the boys was your ability to do CTOs, and the amount of progress and the development in wires and techniques, and now it's it's getting less and less used.
Yeah. So we're going with the 2020 compliant balloon
Any
now.
questions there or no?
Not so far. I think people are just concentrating, and a few may have even gone and opened the guide wire.
So can you ask him the hemodynamic should come here? We cannot see that. Thank you.
So my other observation is that
Yeah, I was ready. Yeah.
most people start joining in the middle of the case, a little later.
But you go to, I mean, I have to, in last few weeks, I have been to two big various symposia in our India, and the Sky Symposium, and the another one is the chip. I would say that so many people come and meet you, and they're so thankful that how we are showing the tips and no industry bias and really techniques to step by step rather than just showcase. And that is why the India actually on the YouTube, India is actually on the top more than America. In the CCC live web, at the web, there America is above India, but in the YouTube, India. And in India, it's a YouTube, on the YouTube, India actually is higher attendance than America.
Well, the Indian interventional cardiologist and the general audience is very much into web-based streaming and YouTube in particular.
Yeah. Go up here. Yep, absolutely.
Have they started doing live cases in India?
So actually, that's again going on. That's a discussion. Although we did for the India valve, we did relay from here and from my hospital in Jaipur. We did that. Dilatal distal. Yeah. But they say that it's not a clear cut yet, but it's people are doing it. And what we'll do in February, which is the India Live. So that's the question coming up at this time. So we will be relaying it on Saturday night. The key is that there is a beacon of, they have few awards. So they're giving me the beacon, some India Live beacon of India Live Beacon Awards, and then that will be on Saturday. Then Friday night actually. Then Saturday night I take the flight, or Friday night I take, and we have live relay from here on Saturday morning.
Congratulations! I think the beacon would be something like a lifetime achievement award.
Yeah. And about the last year they gave about I to go to that with the master technical master technician. Yeah. Technician award. Yeah.
Okay. Making progress.
Great progress, yes.
I thought when the balloon was giving trouble, I thought it is laser time.
Yeah. Go dilate with the same balloon a little bit more.
Bad, very diffuse disease.
Yeah, that's okay.
Yeah.
I'm trying not to balloon.
Yeah,
so
low pressure, that's fine.
Okay,
Yeah.
go up here.
Go. And this is kind of the case people doing nowadays. That you have all the diffuse disease, you just leave it with a drug-coated balloon.
Yeah.
Ours is a trouble because it's a very expensive strategy. If you had to put a 2 drug-coated balloon, you're 10,000 down. Hospital had to apply for some loan.
Done? You want more picture? No,
No,
we have to decide now.
Yeah.
I know several comments, mainly complimenting excellent technique.
Yeah. And no intimal dissection. We try not to do intimal dissection.
So this is, I think, one thing that we want to promote and keep teaching is to avoid the subintimal dissectors and re-entry.
Right.
I'm not a believer of that.
No, but and the data have shown that subintimal dissection have a higher restenosis and we shall come back with the total occlusion. So therefore, the string ray and all that overall use has significantly gone down.
That so and the dual lumen catheters and the...
understand, but that is what is being taught.
Absolutely. I mean, it's just instinctively that has never appealed.
So when you're doing a CTO, you need a nice finesse to do it, and just focus the proximal cap and exit the distal cap.
So we are dilating with a 2.530, and we'll ask people that do want to do IVUS or anything. We have the IVUS ready in case we need it. And I think it will be a good one to see that, yeah, truly there is no calcium. Go.
I think I'll be even interested to know the true size of the vessel.
Yeah.
It may be completely underfilled and maybe larger than what it appears angiographically, but excellent techniques, all with our tremendous technical support from BroadMed AV, their usual excellence. Danny, congratulations on your team. They continue to provide superb support, and your equipment is absolutely world class. I mean, just this is how live cases should be. Uninterrupted, high quality, 3 cameras. There is one from the ceiling demonstrating Dr. Kinney's finger movements in this view, and then a frontal and a side view, all exceptional imaging.
And we are very happy with them. I know the few, there was one of the chip did, that time they did have a little setbacks, but even just we did a live, China relay of the structural case last week, was very good. So, I mean, we are so happy. And right now, apparently this field is so growing. I actually, in last the 1 week, I had 2 companies writing to us that they can do this, they can do that. I said, why would we need it? We are already doing so good. We don't need anybody.
Right. So Anu, more specific, this thing, excellent crossing time. This is Dr. Mahmood El Rais, who joins us almost each time.
Yeah. He always is on the live case.
Okay, let's give a little medicine and let's see, rehabilitate the vessel and let's take a picture.
No, let's IVUS now.
No picture, no, but give some medicine. Let vessel dilate a little bit. Get the real vessel. Artery was sleeping until now, just woke up.
So nitroglycerin is
nitroglycerin, verapamil, all the good stuff, I call them.
Epicardial vessels.
And you saw that once not needed, take the contralateral catheter out. Why to leave it? Start having some trouble, your dissection or more so clot, and so just take it out. So we did it already. We have taken the right catheter out now, contralateral.
No, but you connect. Almost the. Okay, we're going with IVUS.
Sure.
No, take the picture first. We are not taking the picture after dilatation.
We're trying to say how you can save dye. How do you save dye and how to save radiation? Okay, closer. Andrew has the slide ready of the wire.
Yes. Show the IVUS. Sorry, show the IVUS on the screen.
So, I mean, what is the longest CTO you have done in terms of exposure to the patient?
So we actually have not published much on the CTO literature, but I think we have done quite a bit, 30, 40.
Yeah, it's very
40,
small vessel, 2-row vessel.
Yesterday we did
bigger.
a case.
Yeah, looks the IVUS catheter in the true lumen.
Radiation.
Oh, radiation point.
Time and radiation.
Not much calcium, like 2-5 vessel, 3-row vessel. Yeah,
So
slight
no
calcium.
Mostly,
there is some.
Yeah, now come to the healthy landing zone.
No, but calcium is less than 1 arc.
Yeah.
Okay.
Yeah.
So by definition, no calcium or minimal. Yeah. Play it again now, Slee.
Iski, how much was the vessel size distal?
Yeah.
3O. Distal is.
Distal is very like kind of shrink vessel.
2.54.
Yeah, EL to EL is a little bit less than 2.5.
I would say we put a 2.5 and post proximally,
Yeah,
right?
sounds
that's
good.
fine.
Sounds good.
So you want to put
2.5, 48.
48.
2.5, 48 Zans.
There was an area with the significant calcification.
Yeah, but 1 arc, but less than 90.
Like
yeah.
here,
right
like
there,
here.
one.
180.
Oh, no, there are 2, more than 90.
More
Yeah.
than 90, yeah, that's what I thought.
Yeah, very
I can tell you on the
focal.
previous
I mean,
angiogram looked more calcium, but today I could not say. Maybe the Danny's BroadMed AV is so clear.
No, but
No,
see,
no.
there was a
Yes,
view
not-
there.
Yeah.
Again,
No,
you
it is
can't
there.
make out- Yeah.
Yeah. No, on I was definitely there. At few areas of the 280-degree calcification. Okay.
Okay, get us.
This is your
2.548.
Okay,
proximal
now
there, Keith?
what
Yes,
we'll do
yes,
is,
yes. Proximal heresy
now you
landing
take
zone
a
is
picture
3.5
so we can
lumen.
decide where
So
to-
very, very significant tapering of the vessel.
Yes,
Yeah.
exactly.
Beautiful.
Lovely vessel.
Yeah.
All no intimal disruption.
Yeah.
Excellent flow. Now the question is,
Diagonal.
would you address the diagonal? It also looks to be almost a 225,
Get
25
me a
maybe.
fielder. Yeah, bigger
So
vessel.
what we can do,
And a long,
6
long,
French guide.
yeah.
Yeah, 6 French guide will take 2 stents. The two, we put a 2.5, 2 stents can go through 6 French guide, particularly mark guides.
But at that level, it's a bigger vessel, almost 3.5.
Which one? No, but
So
the
you're
proximal,
48, from where do you want to start? So we started just,
after the septal, after the very small septal, where there is moderate disease there to begin with. All
so
the
you
way
want
wherever it goes.
148.
Yeah, 148, and the diagonal 2.75, 15.
So you want, then you will need a 275 because proximal is a 3.5 vessel.
Isn't 2.752 too generous for the diagonal?
No, we are talking LAD. Where he's
Okay,
saying
okay,
we
okay.
can do
No, no,
mini
I meant-
crash
with
with
the
6
French.
French.
Yeah, exactly.
2.5, 2 below stents will go, but a 275 and
Right, will not, yeah.
will not go.
2.5 12 balloon, non-compliant 12 balloon.
Cut it, no?
Yeah, or yeah, give a 2.5 cutting balloon. Wolverine.
Not comments or questions, but lots of compliments, Anu.
We actually are very so surprised that the structural webcast, that almost like no question, rare, maybe 2, maybe the maximum ever,
Right.
compared to our here quite a bit. But more important is, but structure also now having a good popularity. Many of those cases are 4,000 to 5,000 over the month period. 4,000 5,000 hits, not 18,000, which is CCC, our complex coronary cases, but case that is still the lot of.
Look,
Yeah,
it'll be
Hilda.
fascinating to see the impact of providing CME.
Yeah, yes.
You know, it's my own gut feeling here is that although it makes intuitive sense that the US audience will find it most appealing, but I think the value of this even to just about everybody anywhere is and if nothing else, it's a testament to your own ability. You know, you followed the evaluation process, you watched the case, and there is a reward for you to
give some dice
document
so
in your
you know
files
you're
and
not
put
in
it
a
on your
small
walls.
bank, see?
That's it.
Yeah, kept going in the.
And the more important is, right now this is for the live. Now there is a,
Good.
if we do for archive,
Right.
that will be another second part.
I
Remember,
think-
all these things may require the extra cost. So that's okay. We are ready to bear it. Let's see what the response by acute, and then we can put the archive cases also, the CME. So there, I'm sure.
Archived cases, CME is a game changer.
Yeah, that will be big.
And I just hope that, and once again, I want to thank, there are 2 Kims involved in providing and taking care of this CME. A lot of background work has gone into it, and I hope our viewers benefit from it. So, Samin, another question has again come that why, I'll quote it exactly as it is. Why the rush to remove the right contralateral catheter?
Okay. So question comes is the utility of the catheter now. You know your wire is very nice. You have good antegrade injection. So the leaving catheter, what will happen? There is always a chance you make
Thrombus.
some little clot on the tip. Right. And I can tell you, just when we took the catheter out on the femoral artery, there was a clot in the femoral artery. I had to aspirate. There were 2 big chunks. This is on patient with the ACT is already was the 285 was originally. and now 350 because CTO we do give less.
Down.
We don't give a full bivalent bolus. We give 2/3,
Copy.
and that's what we're doing in this case. And keep ACT 300 minus.
Down.
And once you are done, they added additional bolus, and now it's a full
Go for
dose.
it.
And ACT now is a 320 plus.
Okay.
And this is a fascinating, I think this is a,
Go up here.
Yeah.
do not know the name of the doctor,
Down.
but the web name is India Chic.
Okay.
Did patient deny cabbage?
Well, I mean, I would say we didn't offer the cabbage to this patient because two simple lesions, no, not simple lesion.
Ready,
The
take a
syntax score was the intermediate range and a good LV function, but even by the guidelines, it's the PCI would be the first approach. The cabbage could be done, but this case we did not even offer. We had the whole criteria, and we published that now that patients who should be referred for cabbage and they don't decline, then their outcome is slightly lower than compared to who go for intervention based on the appropriate criteria. So in this particular case, we did not even offer cabbage to the patient.
Okay. Down.
If I can read this question between the line as well as to help people's thinking, I think the intent would have been that, look, if you fail maybe one or two attempts with the CTO intervention, then this patient, because of the possibility of still having a lemur to the LAD, of course, would then, young patient, that may have been the intent in this question, but
appropriate. No, I think the failure of your LAD recanalization and then refer for cabbage is appropriate. Now let's put a stent now.
Okay,
put a
2.5.
23 or 20? 23.
Yeah.
2.5, 23 for the diagonal first. Yeah, there is a little bit of distal dissection,
Yes.
but there is whole plaque quite a bit in there.
So what is
this-
LAD now?
LAD we said 2.75. 48,
so
yeah.
this,
Good.
Anu,
but
this
that,
you
we
would be
can't do
calling it
mini crush.
Let's go.
a step crush approach?
No, we'll try to see if we can do a mini crush with a 6 French.
It'll be an issue then.
No, it will go, it will go.
That was 48.
Yeah, only thing is the 48 because the length wise may give a little trouble, but let's see. The 6 French mark, I am big believer. Nobody even company, the Boston Scientific Company can't even say that 2 synergy can go through 6 French. And I showed them the example. Quite a bit. Let's see. This will be the example today. But although it's a Xience has a slightly higher profile than the synergy. The struts are a little thicker, 82 versus 60.
It's not the stent, it is the
Balloon. The delivery system, good. Let's go to other one now.
shaft.
Yeah,
Okay.
good.
If
That's
not,
good.
then we will do step crush. And where is Andrew can show step crush?
Yeah.
If he's still there.
So Anu, people watch this so carefully. This is Nikhil Jha, who I have always
He also
recognized for
yes.
making very
Yeah.
good observation. He says on the app, the mini crush is suggesting 7 French.
That is
Yes,
correct.
yes, yes.
Yeah, this
Yeah.
is
No, no,
Sharma.
very
That's what-
observant.
no,
Very
we know.
observant.
Very observant. No, that is
We
true.
have made
So
it.
I can
Observant.
tell you the mini crush, only 6 French is only Sharma. Even company does not promote it. Company has not done it. I can tell you over the time, I probably had done 100 plus mini crush with a 6 French. Only thing is the stents are less than 2.5 millimeter.
2 to 5 also is okay.
Yeah, or 2.5 and the length, 48, I never tried both of them.
What is
Like 23, 28, 2.5 both will go through 6 French. Absolutely. Now, radial may not, because radial at the level of the subclavian, that you cannot put, sometimes even you cannot put 2 balloons there. So that's a little limitation, but yes, let's give it a try today if we can do it.
No, in the app, we
Yeah.
clearly say that if you have 6 French, 2 things you can do, DK crush or step crush.
Yeah.
If you need mini crush or any other stenting mini crush, you'll need 7
Down
French.
French.
Yes.
Absolutely. And I fully agree.
Unambiguously correct, but I recognize Nikhil for his observance.
Beautiful. Nikhil is a great guy.
Yeah, he's
We always meet us in India. Nikhil, good luck.
in the meantime, Dr. Bharat Ahmed is Sending his best wishes and regards and watching this case closely.
Yes,
Not
yes, I
going?
don't do. Yeah.
Okay. Yeah, it's not going.
See, now what happens is when you're trying this, the stents
There's a
can
challenge with the 6 French.
Yeah.
get us the
So
2.5
because the launch did not go.
Yeah,
We have the 2.5 balloon, just do a crush.
step crush.
The
Okay.
step crush, yeah. So while you're planning the step crush,
Yeah, you can go back.
Okay, go to the, maybe we can start
Can
some
you
presentation.
show the, step crush video, right?
Okay, show the step crush
No,
video
you're
first.
showing a left main. Do we have a non-left main step crush or no?
Yeah, but that's okay.
Not yet. Okay.
The concept. Okay.
Concept.
Show the video of the left main step crush.
Give me the balloon. So what we'll do is exactly like mini crush, but instead of the stent in the main vessel, we have a balloon in the main vessel.
Yep.
We are trying to use the same balloon that we used, the 30 balloon you have. So 2.5. So the difference will be instead of recross kiss like you would have done in a DK, you just put another stent in the main vessel after you did this.
And then do the KBI. All right, so let's go to presentation mode. We have seen the steps of the left main step crush. Our slide presentation now.
No, never used it.
You're in the diagonal wire. Yeah, go
Give
to
me
yeah,
a two.
okay.
Oh, no. We are in
New.
the LED, but
Okay.
then there's a long balloon not
Yeah.
making the thing. Get us
All
a
right.
2.
So I'm going to show that a few more data from the
Give me a
European Society of Cardiology
275
ESC
12, high
2024.
pressure.
We already spoke last time, and then few more, and of course next month will be from the TCT, which is the end of the month, and we have a live relay on the TCT showing both orbital and rotational atherectomy. So AK will show rotational, I'll show the orbital. So this is the senior Rita trial, the flower MI at 3 years, cornea angiography in conservative arm of the ischemia, that what are the predictors, then ECLS shock trial at 1 year.
This stenting, right?
Then focus review of the month is optimizing management of stable angina, a patient-centered approach, integrating revascularization, medical therapy, and lifestyle intervention. So this, let's go quickly by senior Rita trial. Basically, remember we know there have been trial like fire trial have shown older patient STEMI, PCI is good. But what about non-STEMI? And this is where the trial done in UK, senior Rita patient more than 75 years of age, randomized to invasive versus conservative treatment. And of course, in the conservative, if they have unstable, they can always undergo for angiography. And they have a follow-up up to 1 year to 5 years, and overall 4.2 year follow-up was presented. Also, they have very important point of the frailty. Frailty means elderly patient, many times you do angiogram, but you may not decide to do the PCI. And it will be important because frail patient say, you know what, it's not a life-threatening blockage. It's not a left mirror proximal LAD. Maybe let's just manage this patient on medical therapy. And this exactly happened in this case. The patient, the 75 years, randomized half 750 each, invasive and conservative strategy, and follow-up of the 4+ years. Now, as you see, 90% in the angiography group got the invasive, few percent decline, and a few of them medically they felt no need. 90% were radial. Now, but of the 90% who underwent angiography, revascularization was only in 50%. Because of the diffuse disease, because of frailty, and of course 47 PCI, CAB is 3%. In the conservative group, very small percentage, 5.6 had had angiography. There, 80% got the PCI. So just to say that overall, the elderly patient, because mean age was 81, so not only 75, and 70% of patients were age more than 80. So it's a truly is an elderly patient study with a non-STEMI, where STEMI indications are to go for PCI. Non-STEMI, that's where the major, one of the major trial, this senior Rita published in NEJM. Individual endpoints are here. No difference in primary outcome of death, MI, revascularization. As you can see, revascularization was lower. We expect in the invasive strategy, conservative about at 5-year follow-up, about 14% require revascularization, but stroke and bleeding was no difference in both. So just to say, overall, invasive strategy did not do anything. You can say maybe there was about 3% decrease in the MI, but so small. There's a very small in a 5-year period having a the 5-year period having a lower MI rate. So overall, that this is the benefit. The trial showing both primary and key secondary endpoints were identical at a long-term follow-up of the invasive strategy versus conservative in elderly patients. In individual subgroup also, there is no individual group which showed any benefit. So basically, the conclusion was in the older adults with non-STEMI, basically more than 75, an invasive strategy did not result in a significantly lower risk of cardiovascular death or MI, and then a conservative over a median follow-up of 4+ years. Then remember flower MI we presented? That was the FFR guided full revascularization versus angiographic guided multivessel PCI. And they're done in France. We have the 1-year data, and now we have the 3-year data. And you can see here, identical outcome, only 1% difference, which p-value is 0.4. So FFR guided complete revascularization versus angiographic guided primary outcome of death MI and unplanned hospitalization leading to urgent revascularization were no different in the primary Kaplan-Meier curve. So clearly that the FFR guided complete revascularization strategy did not give any benefit. Now, you say, well, maybe in the elderly patient or patients with many of these patients, we not worry about the mortality or MI, but what about the quality of life? See the functional status below with the quality of life, angina score, all were identical. Again, no different between two strategies. So clearly, there was no difference in any of the endpoints in this particular study. So these are the basically primary, secondary endpoint, which I mentioned. Sorry, let me go back one. So what we found here, the only difference basically came is that you have some other endpoints, and lastly, recurrent ischemia requiring hospitalization trended towards better in the angio-guided group. That means some patients, those who require revascularization, they require urgent admission. So this is a p-value of 0.07 in favor of the angio-guided. So clearly, the FFR guided did not help us at all, as shown here. Now there are two trials now, Flowers MI and Frame AMI. Frame AMI actually acutely was slightly better, but if you combine both of them, there is no difference in the long-term, the primary outcome. So conclusion is that patient with STEMI and multivessel disease undergoing PCI, no significant benefit of FFR guided strategy compared with angio guided strategy in terms of non-culprit lesion with respect to risk of death, MI or urgent revascularization up to 3 years. So therefore, there's no need to do the imaging at the time. So this is basically the 3-year outcome, as I mentioned already in the FFR guided. Then another one is that we have ischemia trial. There was conservative strategy and there was a invasive strategy. But what about in conservative strategy, which was patients had a severe ischemia, but they were followed medically. And remember, overall, like in the 5-year time period, about 25% in the conservative strategy require revascularization. But key is they came up with the factor that if you decide conservative, but which patient within 6 months require coronary angiography in the conservative strategy. And this is from the ischemia group. So overall 2,500 patients, and of them 225 require. So about 8.7% require angiography within 6 months. The question is, who are those patients? And there's a big list, various differences and the univariate characteristics in terms of what we do, the procedural point of view, characteristic point of view, but we are concerned what is on the multivariate, which we saw the independent predictors, and these are here. So multivariate analysis basically showed that if you are in Europe versus Asia, in Europe more patients went for angiography than anything related to daily or weekly angina within last 3 months. All those patients underwent cath within 6 months. And then very interesting that LDL cholesterol less than 70, patients did not go for angiogram. It's a negative factor. So really emphasizes the importance of your secondary prevention. Now, you say, what about the proximal LAD or severe ischemia? Look at that. Both of them did not predict angiogram within 6 months. So even your LAD more than 70% on the coronary CTA, or severe ischemia. None of them were predictor of angiography. It was the angina episode, clinically driven, and the protective factor was your LDL less than 70. So this basically puts it together, what we have seen here. And the summary was that in ischemia trial, which occurred within 6-month angiogram, in 10% of cases, and associated with frequent or increasing baseline angina and poor quality of life, but not with the objective markers of disease severity like LAD and so. Well-controlled baseline low-density lipoprotein cholesterol was associated with the reduced likelihood of angiography. These findings point to importance of a comprehensive assessment of symptoms and a review of guideline-directed medical therapy goal when deciding the initial treatment strategy for chronic coronary disease. Now, ECLS shock trial, remember the trial which we presented last year, also presented in European Society. Now they have 1-year data from Germany, basically showed that at 30 there was no difference in ECMO versus control, and now also at 1 year, no difference, exactly identical curve. You say, well, maybe it's the mortality. What about your other factors like cardiovascular, poor neurological status, MI, repeat revascularization? As you can see, identical outcomes. So no difference of ECMO. Now, you say, well, maybe patients who got ECMO, they were more mobile, they will have a better care, quality of life measures, and answer is no. Actually, more patients were confined to bed if you got ECMO versus otherwise, because remember no difference in mortality, but there was higher vascular complication, higher bleeding in the ECMO group. So basically, cardiogenic shock ECMO did not work. So coming back to the our focus review is the stable angina management, is the patient-centered approach, because not only that we talk about giving anti-ischemic therapy, we need to talk patient as a whole and revascularization, medical therapy, and lifestyle intervention. So angina pectoris may arise from obstructive CAD or in the absence of significant CAD, ischemia with non-obstructive coronary disease, which is INOCA, or ischemia is MINOCA. Therapeutic strategy for patients with angina and obstructive CAD focus on reducing cardiovascular event and relieving symptoms, whereas in INOCA, the focus shifts towards managing functional alteration of the coronary circulation, microvasculature. So in obstructive CAD, coronary revascularization might improve angina status, although a significant percentage of patients present angina persistence or recurrence, suggestive the presence of functional mechanism along with epicardial CAD. So basically what they're saying is, patient with INOCA, or even after your successful revascularization, performing a precise endotype diagnosis is crucial to allow a tailored therapy targeted towards the specific pathogenic mechanism. So this they show various trials of the Courage, Barry 2D, FAME 2, and ischemia, and you can see there Orbita 1 and Orbita 2, and all of them, the medical therapy we all know, beta blocker, calcium blocker, avobardine, nitrates, renologine, nicorendal, and trimethoprim, both are not available here, available outside. And basically pointing out that don't just think about you did an angiogram and there is no blockage in the epicardial, your work is done. No. Because many of the functional testing, if you do, even an intermediate lesion, FFR, IFR, abnormal, that basically causing ischemia. So that should be taken care. If not, then you go to the microvasculature. CFR, more than 2 is normal. IMR, normal value is the less than 25. So you need to go further or elicit the spasm. Spasm do occur. Epicardial microvascular spasm by giving ergonovine or acetylcholine. Nowadays we are doing acetylcholine. So therefore, you could have patients have no epicardial disease, but then you could have non-cardiac chest pain because all the tests are normal. Or you have a microvascular angina or vasospastic angina or mixed one based on what you have FFR and CFR. So microvascular angina will be your CFR is less than 2 and your IMR is more than 25. And clearly the vasospastic will be that your FFR is of course more than 0.8 and CFR more than 2 and microvasculature less than 25, but you give a acetylcholine, there is a spasm, and then of course there is a mixed variety of these things can happen. So that's what basically say that patient after the diagnosis on the symptoms, you do a CTA or you do echocardiography, and if the epicardial vessel is normal, then you are talking about the INOCA. Make sure you follow that. And actually, as I mentioned in the European guidelines, there is a lot of emphasis on this microvasculature assessment. Because we know that 1/3 of the patient, despite good epicardial opening, continues to be symptomatic. So So they see obstructive CAD. Once you have left main or multi-vessel disease and diabetic with a low ejection fraction, those patients should go for revascularization, preferably CAT, and some patients will go for PCI. But if a patient does not have a multi-vessel disease and the EF is more than 35 and no left main, then you try to manage these patients medically. By the medical therapy alone, and of course the symptomatic, then they can go for revascularization. So very important point, which they are trying to differentiate that beyond just the revascularization, the patient itself. And this is where they have pharmacological therapy tailored to INOCA endotype. If you have vasospastic angina, you give nitrate and calcium blocker. If you have a microvascular angina, you give calcium blocker and nicorundil. Then you have microvascular angina plus spasm. Then microvascular angina, due to increased IMR or decreased CFR, you do beta blocker. In vasospastic angina, no beta blocker, you give calcium channel blocker. So there is clearly the differential therapy for individual patient rather than you giving all the medicines to one particular case. So with that note, I just want to put it together. The invasive treatment strategy in older non-STEMI patient, no benefit of invasive strategy, but there was no harm also. But FFR guided versus angio guided PCI in multi-vessel STEMI, 3 years, again, no benefit at all. The predictors of coronary angiography in less than 6 months in conservative arm of ischemia trial, we have clear-cut factors. And then ECMO in cardiogenic shock, even at 1 year, is 2 thumbs down. So therefore, the management of stable angina is shifting towards a more tailored patient-centered approach, moving away from the traditional one-size-fits-all strategy involving various anti-ischemic therapies. It is essential to integrate innovative diagnostic and personalized medicine, aiming to customize treatment plans according to the specific needs and characteristics of each patient. An integrated care model that encompasses medical treatment, lifestyle changes and procedural intervention is crucial for an optimal comprehensive management. With that note, I think Anu is about done with the things.
Right? Give
Yeah.
me that. If it
So
goes.
what you have now?
No, we were done.
Go to the
everything.
flora
There's a
now.
dissection in the distal,
Yeah.
because one of the, see there, which
Yeah.
can just do with the balloon.
Yeah. Long balloon.
The diagonal looks absolutely
Yeah.
fantastic.
So you want to go to step by step of the rib.
You know, I
Step
can go,
crush.
but let me put a
Okay.
balloon there.
Yeah.
Now
So
get
we are
me
going to a
new
balloon for a long time.
I
Yeah.
mean, a very strange observation.
You have a 2530,
not
right?
Something you see commonly. You think there is a little myocardial bridge in the mid portion of the diagonal?
Yeah, you
Anu,
could.
let
We
that-
do see, yes.
Yeah,
Yes.
yeah. Very. Several suggestions,
that one.
mainly talking about that, outside the US, this is a straightforward.
Bypass case.
No. The
Or
coated,
drug-coated.
yeah, the
Drug-coated balloon.
drug-eluted, yeah, which
You
is
mean
which
for
I
the
think is
distal
completely
LAD?
right. Yeah, distal LAD.
Yeah.
And a few other suggestions that this is more of a nano crush than a mini crush, but all those are good observation. Samin, many follow-up comments and questions I have regarding some of these are very important trials, and the British Heart Foundation always surprises us by picking beautiful issues. The issues addressed in Senior Rita are so different than what the traditional approach has been, that the invasive approach is even more beneficial in the elderly. So very clear change in our thinking, which is consistently going with the guidelines. I've been watching that more and more in the guidelines, the emphasis has now gone into the cognitive functions in the elderly, the life expectancy, all I think in the right directions. Now, on the other hand, I think there is a needless, that title is so provocative and so, so appealing, lifestyle changes. Those changes are required for every patient. Any patient we see in the cardiac cath lab with or without obstructive disease and clear INOCA, lifestyle modification has to be at the base. I often talk to Dr. Kinney about it, who's the most perfect believer in this, and I hope at some stage we'll follow it. Now, the specific question I have for you is, why does a post-STEMI additional non-culprit lesion on the basis of flower, again, it's not surprising, but why is it so different than the FAME2 population or something where FFR had such a big role?
Yeah. So I think the basically what happened is, and the people have said also that many times the FFR, sorry, changes in these patients when you bring them in 3 to 6 months because of the various vasoactive tone. So question basically comes down to that angiogram, and this is again the lesion which has to be like 60 to 90%. The CTO were not part of it, and so those question is that what are your FFR measurement in this acute situation when there is catecholamine, there is vasospasm, the FFR could be falsely negative.
Right.
So that's basically I would say the only answer will be, in the MI setting versus stable setting of the FAME.
Exactly right. Yeah, completely agree with that. Anu, you were going to tell us something about the case?
Yeah, so this is where we are. This is the placement of the stent.
And if we need to do
Yeah.
the drug-coated balloon, we can put a 2.530 drug-coated balloon. Try to look
So
agent. There's no 40 millimeter, right?
let's go
Agent balloon, 2.530. If we have it, we may decide. I'm saying if you want to, you can decide with the case of the distal. Now, other question is there was a paper actually in the
Can I
CTO.
finish showing?
Yeah.
Okay, so this is where we are. So you place the side branch stent. This was at 14 atmospheres. You take out you check that everything is okay. Again, this is fluorosave. We don't go on full cine. You remove the wire, and this is where you are. You crush that stent. This was 2.5. We went to 20 atmospheres. Now we are able to get our, see, this is the 48 stent. Went easily. 275, 48. That's how we placed it. This was again at 12 atmosphere because the distal vessel was just 2.5. So this is important. So proximally we know the vessel was 3.5 and distally was a 2.5. So we put a 2.75. You definitely need to dilate. So proximal you will post dilate. Proximal optimization, we did it with the 3.5 15 balloon at 20 atmospheres. Then we were not able to, we wired the diag, not able to get a 2.5 high pressure balloon into the diag. So what you do is anchoring. So we had the same 3.5 balloon at 3 to 4 atmospheres in the distal part of the LAD. We anchored it and able to get that 2.5 high pressure balloon into the diagonal. Then we did the kiss, and this is where we are.
Look, so much background work went into creating this outstanding result. I mean, this is each step addressing the diagonal, getting back the balloon for the final kiss, the part for the lesion, just all excellent learning steps.
Yeah. And there's a little
That's it.
dissection. We're doing a prolonged balloon inflation.
Right.
And you know, there is a paper in JAC intervention showing that once you have the myocardial bridge in the CTO is associated with adverse prognosis. So which is not uncommon, and we encounter myocardial bridge in about 18% of cases, every 1 in 5, but that is associated with a higher restenosis in the future.
One of my clear appreciation is what you kind of mentioned about. I wanted to take up that issue. I think
Drug-coated balloon. Yeah.
we are going to be dealing more and more with INOCA, without doubt. And you know, I think the CMS will approve funding for coronary physiology. I think additional coding will be there. We'll figure out better doses. I think the protocols at the moment are okay. I'm not so sure they have been perfected regarding the dose of acetylcholine, the exact follow-up going between adenosine and possibly even the measurement of the IMIR, I think, will become easier. You know, there is a question as to what is the best way to do the cardiac output. Should it be the Doppler wire-based or thermodilution? So, but I think we'll hear more of it. And it is also my feeling, I'd like you've been very focused over the
Change
almost the last 2-3 decades on gender issues. I think Inoka kind of plays
Change
also
the
a
screen,
little more towards that
IVAS.
too.
Absolutely.
Okay, let's start
Yep.
the IVAS.
Change the screen. 1 second.
So you need to do the IVAS first,
Okay,
because
start
once
feedback.
you do the drug coated
coming.
balloon,
It's a
you're
native.
done with the procedure.
Yeah, edge is good.
Okay, distal edge looks good.
Yeah, stent is
You
okay.
are 2, right? 2 millimeters.
Yeah,
Kiski,
it's four-
do you
it's four.
think the stent needed to be expanded a little bit more, or you like?
Yeah,
the
I can
expand-
check the area because this is small vessel. I think okay expansion. I can check the area. 1
Actually,
second.
by outlook looks okay. Even dissection, I don't see much, although how far
No,
the
no, I
catheter
didn't
was.
go down because I didn't
Yeah,
want to.
that's what we
because
didn't
exactly,
see.
yeah.
So yeah.
I just stopped at the distal edge.
Yeah, actually the distal stent area is like a 3 point something, like a 3.8, but distal reference is less than 3, so it's a more than 90% expansion. I
Excellent.
think it's an optimal stent expansion, intra stent.
Wonderful.
Yeah, and proximal is much bigger, and no malposition and no dissection. So I think stent is perfect.
Okay.
Good.
Side branch.
Stent is optimal. The question comes here is America versus outside. Outside, everybody will put a drug-coated balloon. Should we do a drug-coated balloon now? Okay. That's the key. What do you need?
No, I'm doing side branch because Kiski always likes side branch IVAS.
Sure.
Wow.
But don't, I went to 20 atmosphere at the ostium, okay, Kiski, with high pressure balloon. Want to make sure ostium looks good.
I mean, one more issue, and again, thank you so much. I truly hope that,
Come closer.
often this is what people tell you in their conversations regarding CCC live cases, that it truly is a comprehensive. You watch the case, then you hear about the clinical trials, and you covered 3 or 4 such relevant
We do
trials
IVAS
today.
again.
What do you think is the reason? Are you a little surprised that ECMO was
start with
not effective?
Well, actually, you know what? We're surprised, but it's consistently coming out with so many.
Yeah,
The
sideline
ECMO is
stent
not
also
effective in
looks
this
nicely
cardiac issue. These
expanded.
are not the end cases, but consistently.
is
Euroshock, ECLS shock.
Is this because we probably need to focus more on the patient who demonstrates more hypoxemia and
Yeah,
more,
so no, they
pulmonary
actually, I
issues?
would say, they actually had nice that lactate has to be 4 and so, but I think point is, the vascular complication and bleeding is so much.
Right.
That's the reason. Sepsis, vascular complication, and bleeding. So even if you survived initial insult, those will kill you. So that's the problem. So the day things go down, and that's where I would say that danger shock, Impala help, because Impala is 14 French and ECMO is 16 to 18 French. So few percent point is different. So let's finish it now.
Yeah.
And you tell us whether
No,
drug-coated balloon or not balloon.
ostium,
Osteal diag is 5.0. It's very exciting.
good.
Yeah.
very good.
Okay. Only question remain, your drug-coated balloon or no drug-coated balloon. Another $5,600 expense or not?
Probably not.
To me, we would leave this
I mean,
alone.
because the young guy, I mean, I'm just saying that
I
he's
know,
a
once
young guy.
upon a time when nothing existed,
Yeah,
this
that's
used
a
to be
different
left
thing.
alone,
Yeah.
and
So
he
Let's
need
take
to
a
be
good
brought
picture.
back.
your
Magnify,
feeling is
magnify.
that what threw tandem heart out of favor is what is putting
Yeah, ECMO, exactly. That is correct.
So probably no, there the dissection
Yeah.
looks more actually,
more,
both in the mid
Yeah.
and the.
Right.
I think you need to do something there based on
The-
that.
So
No,
to
what
me,
makes you think a drug coated?
no, I would say the other way around now.
Yeah,
With
put
this
a
much
stent.
dissection, I think put another short stent there. 23 millimeters, so
I would
2.5.
put a 28,
28, yeah?
Distally.
2.5,
not
yeah.
2.5, 2 to 5.
Yeah,
Okay,
it's
2 to
true.
5.
Yeah,
Yeah, because
the
long-
distal vessel 2 to 5. Yeah.
Yeah, long dissection. I mean, you can
2.5,
leave this young guy, but you leave it still enough room for Lima ever.
Yeah.
But you had to take care of that.
So I mean the little haziness which you see more at the end of the
play.
angiogram, you think that's just flow related and not? I think it's just the last end part of the flow which shows you some.
Yeah.
Yeah, there was nothing on IVAS either,
Yeah,
so
yeah,
we
no.
have a good confirmation.
Yep.
So I think maybe ECMO will truly be left for the young out of hospital cardiac arrest
Cardiac arrest,
patient.
yeah. And patient with a multi-system disease or maybe with a heart failure. Remember, these are the patients with STEMI causing cardiogenic shock. So non-coronary cardiogenic shock, caused by systemic infection or other, there is a value of multi-system disease. But in the cardiogenic shock is the one. So these are the STEMI caused by cardiogenic shock.
My greatest, it's one thing is to watch all these trials and concentrate and try to apply the lessons from clinical trials, but often what you see in real life stays with you. The ECMO which we used in the case when Dr. Spencer King was moderating the session with the left main, to me remains always the way you salvage patients.
Yeah. Oh, acute emergency, absolutely. Yeah. So they cath lab savior. So 100%. So that is why even when I made the presentations in India, I said good lab has to have this portable ECMO. Just like ESCC, we have two actually portable ECMOs because we needed at the time of the COVID. But one ECMO we have for last 10 years. Same thing, Mount Sinai, we never used to have ECMO before, but we have the ECMO now. Look at such a beautiful picture now.
Yeah, excellent.
Wow. Beautiful. Now, Anu,
any other questions for us?
Any question for AK?
Yes, many questions. There are some observations about, again, drug-coated balloons. Is there a little under-expansion of the stents? But I think all of those have been covered. And I want to thank our viewers, dedicated viewers. Along this, I'm seeing a list of about 15 or 18 of them asking exceptional questions. I want to thank all of them.
So just to say 3 questions, because we wanted to update whatever we have presented, senior reader trial of invasive versus conservative treatment of older patient with non-STEMI revealed the following except similar primary outcome of death and MI, similar stroke, similar bleeding, lower non-fatal MI in the conservative treatment and lower revascularization in the invasive treatment. Answers are all correct except the D, that there are no non-fatal MI, is identical. Second question, following are the true statement for flower MI at 3 years, higher MACE rate in the FFR guided group, higher recurrent MI in the FFR guided group, trend towards higher hospitalization with ischemia in the FFR group, higher revascularization in the FFR group, and higher stent thrombosis. Clearly, there was trend towards higher hospitalization with a p-value of 0.07. See, last question. Following are the independent factors on multivariate analysis associated with need for coronary angiography within 6 months in the conservative arm of the ischemia trial, except LDL less than 70, proximal LAD stenosis of more than 70 on CTA, and daily angina frequency, new onset angina in last 3 months, and randomization Europe versus Asia. Answer is even the proximal LAD did not ask for, or the patient did not require coronary angiography, so B.
We conclude today and we'll see you on November the 19th.